My name's Nita Patel. I am the Associate Director for Research Engagement at Barts Health NHS Trust. Myself and James together form the Research Engagement team, and we work with our researchers and our patients and public, both across researchers across QMM, Queen Mary University of London Medical School and Barts Health NHS Trust, to make sure that we're building strong partnerships with our patients, local residents, in the design, the development, the delivery, and also the sharing of the results of our research. Every year we host an event to sort of mark International Clinical Trials Day, and for those of you who may not be aware, International Clinical Trials Day marks the first ever, so it's James Lind, first ever clinical trial was supposed to be conducted by James Lind. It was a trial around scurvy. It was conducted upon a boat, I think, a ship. Thank you. Yasmin knows better than I do. But that International Clinical Trials Day is celebrated every year to just sort of try and help us to promote research and raise awareness of those studies. So last year, for those of you who did join us last year, we had a really interesting programme. We felt that post-pandemic, with the spotlight that was shone on health inequalities, we felt that it was really important for us to give people a chance to showcase the work that they were doing, to be more inclusive in their research. So whether that's patients that they were involved, members of the public who were helping to advise on studies and the topics that we're researching, as well as sort of things like how we're engaging with our patients, what sort of experiences are our participants in studies having, and what can we do to improve that. When we came to think about this year's programme, we were very kind of like, we don't usually like to sort of run a topic twice, but we felt that there's so much happened in the previous 12 months that it actually justified us doing another session focusing on the topic of inclusion and diversity in research. So I think we've got a really, really nice programme together for you today. We just wanted, before we sort of start with the speakers, I just wanted to do a little bit of housekeeping, if you'll permit me. So for those people who are online, please keep yourselves muted. We will ask you to put any questions and comments into the chat, and we have Laura who's monitoring the chat online, and she'll help field those questions later. We are recording this session and we will be taking a few photographs. So do please, if you're online and you don't want to be featured, do keep the camera switched off. For those of you that are in the room, there are no video cameras pointed at the audience, so you don't have to worry about that. Questions I've mentioned in the chat. For those of you who are at the lecture theatre, just to let you know where the toilets are, you can go out of either of those two doors, turn right, and then left, and they were just along there, and there are accessible toilets, ladies and men, just along there. There are on your desks little slips. So you've got two documents on the desks in front of you. One of them is a programme. We will, thank you. Yeah, we would have had a slight change to the programme, which I'll talk about in a moment, but I just wanted to mention the other slip. So there's a slip of paper with 3 little QR codes on. At some point, we will be asking you to ask some questions. So if you've got your phones, if you can scan those codes at the appropriate time and take part in our little pop-up questions. Those of you online, we will be posting those links in the chat. And the Wi-Fi codes for those of you on, that need it are on those slips as well. Great. So the change programme, unfortunately, one of our speakers has been taken ill, so Jo Morgan isn't able to speak today. So we've rejigged the programme a little bit. Christine Menzies from the NIHR Clinical Research Network North Thames. I'm being very mindful of my abbreviation. By the way, I should just say, if I abbreviate and you don't understand, please do not be shy about sticking your hand up and telling me off. And I'm happy to explain. Christine's going to do a little talk for us on a project that Barts Health has been involved with over the last year. It's an NIHR program called Research Ready Community Champions. And then we'll have Will from the Applied Research Collaboration, North Thames, who is going to tell us a little bit about what they're doing to be more inclusive in their research. And he's brought along two of his advisory group members, is that right? Wonderful, so we'll introduce you later. We'll have a very short break around 6:10. You'll have some time to ask questions of the speakers at the end of each session, so do pop them in the chat. And in the room, if you have a question, we can obviously raise your hand and we can come to you in the room. We have someone with a roving mic who will do that for us. Is there anything else that I've missed out?
That's all the programme.
Right, okay, I think that's me. Oh, yes, me.
Can you take pictures of the screen?
Yes, you can.
Thank you.
Yes, you can. And I will say, we do usually ask all of our speakers to share their slides afterwards. So we're happy to, well, we will send them out with you. We tend to just do a thank you with our email address list. But that's fine. So without further ado, we're going to go to the first Slido. Thank you, James.
That's good.
So you take your slips out, and you want to scan that first QR code on the page. Is Laura posting it in the chat?
She should be any second now.
I am. It's in there now.
Wonderful. So my first question is, what does inclusive research mean to you? We're going to see if we can get some responses together and build a little bit of a word cloud. If anyone's having any trouble, let us know and we can come around and help. Probably won't be me. Excellent, thank you. So represents all, regardless of race, diversity, everyone, and fair. These are obviously really common responses. Tailored research, public participation. Maybe another minute to see if people are still feeling ready. We can go to the next question. Excellent. Should we do question 2?
Yeah.
You can keep completing those, and they keep
Some really good responses.
Over.
Give it another minute. There's still some coming in. But...
Yeah. Okay.
Yeah.
Yeah. Don't want to do too long then. Great.
Answers there.
Yeah. Fantastic. Shall we go on to the second question then?
Yeah.
So next question for everyone in the lectures and online. Have you ever taken part in a clinical trial?
Mixed bag.
It's probably one or two people.
Very even.
That's very even, actually. And I would also say that's probably the first time that we've had more people say yes than no. Are people still scoring? It's nice to know that people know one way or the other whether they took part. I did put the don't know in there because you said, I don't know. Thank you. Should we go to the third question?
Yeah.
So we wanted to know, so the statement is, I have helped to shape research at Barts Health. And we'll talk more about what it means to shape research later on.
Good. Still some coming in, actually.
Again, that's quite high.
Yeah.
I imagine, given that we've got quite a number of staff and healthcare professionals, I suppose the result on that is slightly skewed. but it's nice to know that we are up there. We've got a number of public contributors in the room as well. So, right, okay. So I think thank you very much, everyone, for completing our slidey questions. There'll be a few more throughout the event, so do keep those QR codes handy. And I think people are probably fed up with hearing me, so I'm going to actually hand over to Christine, who's online and who's going to give us a little bit of talk about the Research Ready Community Champions. Thanks.
Bear with me one sec.
Just wait for the slides to come up. Can you put the slides in like a slideshow format, James? Okay.
Yeah.
Please. Thank you. Okay. Thank you very much, Nita. Okay. Yeah. So my name's Christine Mingus, and I'm the API lead for the Clinical Research Network of North Thames. And there's a bit of an echo here. Is there an echo at your end? So can you hear me all right? It's got a slight echo on my end, but
I can hear you all right, yeah.
Oh, that's fine. Okay, I'll carry on. So for the next few minutes, I'm going to give you a brief overview of the Research Ready Community Champions Programme run by the NIHR. Now, I'm going to be co-presenting this with two of our great community champions, and that's Sharifa Patel and Sultana Ralph. Unfortunately, I wasn't able to be present at the meeting today, so yeah, I'm online. But the two champions who I'm hoping are actually in the room with you now. Just before I start, and I'll always say this to people who haven't met me, I do have a stammer, as you've probably gathered already, so I might take longer to say certain words, but if you just bear with me, yeah. So next slide, James. Thank you. Okay, so okay, what is the Research Ready Community Champions Programme trying to achieve? Well, basically, it's trying to make health and social care research more inclusive, and it's trying to make the research more reflective and representative of the needs and interests of our communities. I'm sure you're all aware that there are numbers of the population, pockets of the population that are not represented in much of the research that's being done around the country, such as, I'll just name a few, such as people with disabilities, people from ethnic minorities, asylum seekers, homeless people. There are a few more, but so as I say, the long-term aim is to try through the help of this program to try and make the research more inclusive. James, the next slide, please. So how does the Research Ready Community Champions Programme actually do that? Well, this just in a nutshell, the aims are, well, we do this through our community champions who build up, well, we build up trust with, and we establish long-term working relationships with the community champions and therefore with their underserved communities. And through the help of the champions, we listen to their community members. We want to hear from them what additional information and support do you need in order to be able to take part in research. And the final aim is, and that this is not just a one-off piece of work, and that this is a long-term project, because we're just starting to build up these relationships with a small number of champions in North Thames, but we want to maintain this moving forward because as I'm sure you can all appreciate, it is going to take some time to make, you know, clinical research much more inclusive and representative. So the next slide, James, please. Okay, so this slide gives a nice overview of the whole programme. I mean, basically, the LCRN start off by working with our partner organisations across our region, and through our partner organisations, we find a small number of community champions, and these are generally people who run or lead underserved communities in our region. And these champions are then given training, and they then have go back to their community members, have conversations with them, and to try and gather views about, you know, what do they think about when they hear the words health and social care research. Where do they go into communities to find information? Have they ever taken part in a trial, etc.? And then we come together with the champions and the partner organisation contacts following the conversations. We, you know, put together an agreed action plan, and then of course the plan is then to actually act out the actions. And as I say, this is it's a long-term piece of work. You know, so yeah, that's kind of it in an overview. I'm now going to talk about the work of the champions and then the work of the partners before I'll give you an overview of where we're at in North Thames with the programme. So James, if you move the next slide, please. Thank you. Okay, so the community champions, what does the role involve to them? Well, basically, these community champions are given some free training at the beginning, to give them the skills and the knowledge about, you know, health and social care research, and they're also given some training about the NIHR, plus they're given some practical skills to actually run workshops and to have conversations. So after the training, they go back to their communities and, as I say, they hold conversations, you know, either in a workshop style or in some cases on a one-to-one. And they ask them a multitude of questions. We actually agreed some set questions within our little working party within North Thames. So yeah, and then alongside that, the champions also carried out some community mapping, so they actually physically, well, in some cases, walk the streets of their local area to take a note of venues within their neighbourhood that they thought that local people might go to find out, you know, more information about health research, etc. And then we actually map these with James's help, I have to say. And then we invited the champions to a review workshop along with the partner organisation contacts. We reviewed all the conversations, the outcomes, and put together a short agreed action plan. And we're now in North Thames at the stage of, well, trying to do some of the actions. We're not quite at the stage of celebrating success just yet, but we hope to get there in the near future. James, can I have the next slide? So you might be wondering, well, what sort of skills do the champions require? Well, they should be individuals who are keen to listen to other people's opinion, they need to be passionate about, you know, health equality, and what wanting to make a positive change within their community, and they should be well connected as well, and able to work in a team, and they don't necessarily have to have a prior knowledge about, you know, research, because, as I said earlier, they are given training. James, the next slide. And now, what about the partner organisations? Because they're also key. Now, at the moment, not the partner organisations working with me on this programme are Barts Health, QMUL, and UCLH. But moving forward, I'm really keen actually to work with partner organisations that are not necessarily hospitals or trusts. For example, I think it would be great to work with some charities. I'm trying to engage at the moment with a charity in Dalston called Community African Network, as well as one in Enfield called the Caribbean and African Healthcare Network. And I think these would be two great organisations to work with, and to try and find champions from these respective groups. So, but yeah, the partners work with myself and the champions on the whole journey. Okay, and the next slide, please, James. So, what you know, attributes do partner organisations need? Well, very similar, in fact, to the community champions, and they need to be, you know, passionate about, you know, their drive towards more inclusive research, wanting to make, you know, positive change in the community, be well connected, and they want to, you know, work with more of the underserved communities across their their local area. Plus they need to be able to give support as well to their respective champions. So, okay, James, the next slide. How am I doing for time? By the way, how am I doing for time?
You're okay, I think. Yeah.
Okay. Well, where are we in North Thames at the moment? Well, we've got three great community champions. Okay, we've got one linked to a women's health group in Finsbury Park, called Janity, and two who are members of Katie's team, linked to Barts and QMUL, and one of these champions runs our own disability forum in Newham, and the other champion. So I missed yeah, my speech is going a bit haywire, but yeah, thanks for. And the other champion, who is based in Tower Hamlets, has got some great connection with the likes of the Health Watch Tower Hamlets. Plus, she has also co-produced studies in the past, and this is actually a picture of me and Sultana on our community asset mapping walkabout in Tower Hamlets. Yeah. Now all the champions have been trained, and they've had their community conversations, and we've held our review workshop, and we're now at the stage of trying to put together some actions. And one of the actions that the champions suggested was to put together an easy read newsletter listing some of the kind of easier to take part in open trials, you know, and they also what wanted to see this on a regular basis. So I'm currently working with our comms team and to try and implement that. Now, a number of community members asked for information about current trials that they could maybe take part in. So we're arranging for researchers to actually go out to the communities via the champions to speak to these groups about their research. I've included 2 examples here. One is the baby study, which is a genetic linkage study, and also the for pregnant women running in East London, and also the GLAD study, and for people with anxiety and depression, looking at genetic factors. And the next slide, James. I'm almost there now. I'm not going to have time to go through all the qualitative and quantitative results from all the conversations, but I just actually wanted to highlight a couple of things. Firstly, I thought it was quite staggering that about half of the community members were not familiar with the term health and care research, plus about half of them were not aware that their local hospital supported research, plus over 30% of them actually didn't think that research should be offered as part of normal routine care, which I thought was a bit disappointing. So clearly there's still an awful lot of awareness raising that's got to be done. To talk about the fact that clinical research is safe, and we it can actually benefit you and the community. So and through the help of the champions, we hope we will be able to change the attitudes of these community groups. I'd like to in fact ask the members the same thing, and say a year's time to see if they have changed their views about supporting research.
Christine, just to say, we are running a little bit behind, so I was wondering, have you got anything for Sarifa and Sultana?
Well, I'd like like them both to come in now and talk about what they have, have gained from being community champions.
Pass it over to Sophie.
So yeah, if they could.
Hi everybody, I'm Sarif Patel and I run two groups in Newham. I run the Disability Rep Forum, which is our service user-led group, all disabled people and impairment. And we come together every second Tuesday of the month at the Flower Centre and we discuss what's working, what's not around communities and around our needs as disabled people. But I also run a group for parents of disabled children, sometimes disabled parents themselves. And we try and unite them together as well, and we bring them together as well, because there was always issues around disabled people with carers, but I try to unite them, because sometimes our issues are the same as carers. Being a community champion has been really great, because we've had training. Another good thing about it is that my community hardly ever heard about health and care research as disabled community, which was shocking when we did the research. And it was interesting to find out, that they really wanted to be part of it, but they were never offered it, and they didn't know how to get involved in it. So that was interesting. The other interesting part of it is we are all from the BB community, Black and ethnic minority, and there's a lot of issues around language barriers, around a lot of issues around accessibility, and as carers as well in our group. What they were saying is that when research is offered, if ever, it wasn't offered, but if it was in the possible future, that what they would like is to have it at the same time as when they're meeting up for an appointment, because otherwise they're having to look out for who's going to be looking after their loved ones. So that's what came out of the conversation. We found it really good because it gave us a platform for us disabled people who hardly ever get asked in research or healthcare and things like that, and it gives us a platform, and that was really appreciated by my group, and they were really interested in being involved with the research program, which is really good because now I've got a couple of people coming to talk about some of the research that's happening, and so my group is going to be aware, so I'm really grateful for that. Thank you.
My name is Sultana Roof, and I have done community research in the past, and presently I'm part of Katie's team. And this training program was really great because it was kind of covering the theory side, the research methods, as well as different ways of getting the research done, as well as more sort of information around clinical trials. And as I was doing the research in the community, I attended a women's group, Collingwood Women's Group, and a nursery as well. And there was a kind of big difference. A lot of negativity around the idea of clinical trials. Quite a lot of people thought it's about taking your blood, being intrusive, not kind of benefiting the person in question. But through my bilingual skills, I was also able to explain it in Sylheti, Bengali, to these women and tell them that, the assumptions that they had, were not quite right, and the experiences they can have, as well as the opportunities out there to take part in clinical trials. Again, like Sharifa said, there isn't enough awareness in the community, and people actually do want to take part but don't know how and where to go. On the other hand, I also found that not a lot of men were involved or interested in taking part. So as in the future, I think that more men should be recruited as community champions, as well as more people who have either language difficulties or accessibility difficulties, so that we're encouraging more people with hidden disabilities to take part. Thank you.
Thank you both so much. Christine, did you have any final words, or shall we go to question and answers? Up to you.
No, that's fine. I'd just like to thank Sultana and Sharifa for being, great, and engaging champions. Yeah, really passionate, and yeah. So yeah, I'm sorry I can't be there. Thank you. No, yeah, you really make it work, because you're so engaging. So thank you.
One of the things so when Christine first approached us about the Research Ready Community Champions programme, we really jumped at the opportunity to be a part of it. And I think from my point of view, one of the big successes that by working with champions, we've all almost kind of taken a big step towards building that trust, because a lot of these individuals that we're working with, you've been associated with these groups and these communities for a long time. You've built up trust. You've then built that trust with us, and that's come over time. And I think slowly but surely we're making those inroads. And I think from a research engagement point of view, we're really keen to make sure that all of our researchers have kind of access to community groups through the Research Ready Community Champions programme. So we're hoping that the staff that are online and in the room bear this in mind, take this idea back to your colleagues and approach James and I. We're working at building up Zarifa and Sultana are just two champions. We are hoping to build our little network of champions in the future. So we might not be quite there yet, and we certainly don't want to overload our two champions. We want to share the load. But do come and talk to us, because we think this would be really a fantastic way of reaching into those communities, talking to them about your particular studies and your areas of study. So we've got a few minutes for questions. We always run a bit loose with time. I do apologise for those of you who are clock watchers. We tend not to worry quite so much about that. It's about the quality. So first of all, are there any questions? Any questions in the room? And James, could you just check online and see if there are any questions online?
Don't think there's any come through via the chat.
We've got one question in the room.
One in the room.
Hi, Sharifa and Sultana. Thank you so much for your time and effort in being our research champions. I do have one question in mind. I'm one of the IBD research nurses, and so far, feedback from patients, if they have a positive experience in research, they keep coming back to do more research. However, for those who did not have a positive experience in research, they tend to not do any more research. For example, patients who did not get better in doing a clinical trial. Have you ever had some in your community, for example, who you've encouraged to do research but did not have a positive experience, and because they trusted you, you encouraged them, did they come back to you saying, you've told me to do research, but I didn't have a good experience with it? How did you respond, if you had any experience?
Yeah, I have. I'm going to give you, because we've just realised that we've only got one mic, so if I hold this. You're coming back? Oh, bless you. Bless you.
I have, and it's my own husband. He was involved in a diabetes research program, funny enough. And first of all, he had a positive experience. Then along the line, he had a negative experience. And then he wanted to drop out. And then, we talked about it, because being like a lion carer. We talked about it, and I said, well, what's been good, what's been bad. And I think it's like where it was a long way to go, and there's accessibility, but he masters a lot, my husband, he has communication difficulties, so he doesn't explain that. So then the next time we had an appointment with a research nurse, I went with him and then told him that he's not told me this, he's not told me that. And then after that, he started having a positive experience. So then he wanted to take part again. But that's what it is. It's about working with them, listening to them, see what their barriers are, and then addressing the barriers. And that's not just for people that drop out, it's people to start as well. Because some people are nervous around clinical research. Are they going to be like the guinea pigs? Are we, are they going to experiment on us? So it's to reassure them, it's to build that trust, and it's to say that, it might not benefit you now, but it might benefit other people in the long run. And what the benefit of it is now for you as well, that you get regularly monitored, hopefully you have a positive outcome. So it's about reassurance, it's about building that trust and that relationship. But what's important for my community is, like Sultana said, people with language barriers, to make sure their language barriers are addressed. People with accessibility needs, to make sure that is addressed. If they have caring responsibility, to make sure that they have got the carers sitting, service, or we've got some way of funding them to make that happen for them. Yeah, so it's those kinds of, because when people know that you've got all this in place for them, then they're going to join you. Yeah, thank you.
Sometimes you want to say something.
Yeah, I just wanted to add, I haven't had a bad experience, but through my work as a community researcher for Brun Bible Centre, I've created that trust within my community, and I kind of have seen that people, if they have an incentive like involved, then they're more likely to take part, and if interpreters are provided, if refreshments are provided, so things like that really make a huge difference.
Excellent. I just want to make sure I'm on camera. Right, thank you. So we're going to move on because we are running very, very behind, and I know I said loose, but not that loose. So I just want to say a big thank you to Christine online and to Sarika and to Sarika. Thank you so much for your time today. So without further ado, I'm going to invite Will and Martin and Shadir to come up to the front.
Yeah.
James, you just gave me your slides.
It's all good. It's all good. Take your time.
Here we go.
Y'all sit there. I was gonna. I'll stand. I was gonna stand for my part, and then we'll. Okay. Ready? Everybody ready? Here we go. Let me do it all professory. Is there a freestanding one? Can they hear me online if I talk?
So we've got the free mic here,
Okay.
if they're happy to share.
Can they hear me online if I don't use it, or are they rather?
So your mic is up, Will,
Ah, perfect. Oh, y'all got the table. I want to get some of those actually.
and the handheld is for your desk.
Great. Okay. So I will sit this here and pass it on. Okay, cool. Here we go. So hey everybody, thank you so much for being here. My name is William Lamons, and I am the very proud patient and public involvement and engagement lead at what we call the ARC North Thames. So it's another one of these wonderful research collaborations, and I'll get right into it. I'm joined today by two wonderful public collaborators, Mr. Martin Fisher and Mr. Sudhir Shah. We'll let them introduce themselves more formally in just a minute. I'm gonna do my part for about 5 minutes, and then we'll have a little chat with everybody else. But so our talk today is called Reflecting on Patient and Public Involvement and Co-Production to Support Inclusive Health Research at the ARC North Thames. So first, I want to start with my favorite image to explain this concept. And today is probably the first time that has challenged me to think about this image actually in a different way. So typically, I explain it like this. I say the figure on the left is a researcher yelling, at the member of the public who is falling asleep because they are so enthralled at what the scientist is saying. You good? You good? So I in public involvement, try and live here in relevance to try and create some kind of dialogue in between this. One of my favorite critiques I've heard in almost 3 years of working in this space in the UK has been the critique of hard to reach, that we are not hard to reach. You just have to come to us, right? So it strikes me that the things that the public say could also easily put the researcher to sleep if they're not as willing to engage with them. So this could very easily be kind of a back and forth sort of thing. But through these practices, I really invite us to live in this space of relevance in between where we can have a dialogue that is equitable and that acknowledges and supports different. My doohickey is not working. Sorry. Got it. So first, I want to explain to you what patient and public involvement is. So basically, it is this dialogue process. It is doing research with or by members of the public rather than about or for them throughout the entire research cycle, starting as early as you can, doing it throughout the entire process. So where it's not just a top-down kind of research, but where it's collaborative and you get to work with these wonderful networks like we've just learned about in the previous talk. So this means that people are actively involved in research projects and in research organizations throughout the whole thing. Public engagement, by contrast, is the kind of what we call the one-way street. So it's where you share key research information in ways that speak to people, whether that means by translation, whether that means through different engaging sorts of images, whatever it may be. So I want to talk a little bit about the organization where we all spend time working. We are funded by the NIHR, or the National Institute of Health and Care Research, and we are the ARC. We are one of 15 ARCs all across England. ARC stands for Applied Research Collaboration, and we are based in North Thames. So that's a fun geography that exists mostly in the world of the NIHR and does not exist terribly in the real world. But basically it means from the north side of the Thames River out to the East End, up into the north side of London, and it dips into all the counties that fill in there, however you want to say it. I have a different breed of English than is typically spoken in this part of the world, so I hope you enjoy. The whole point of the ARC and of all the ARCs is to do applied health research and to do research on implementation or things that affect people's real lives. To make research, to do research and to do it in ways that are relevant to real human beings and what they need. These massive, so we are a massive interdisciplinary sort of entity that includes collaborations with all kinds of different things, including healthcare providers like Barts Health, universities like Queen Mary, like UCL, where I'm based, local authorities, different community organizations and peoples. It includes about 125 different studies. So it's this massive kind of scale. And we include 5 specific research themes: multimorbidity, population health and social care, mental health, innovation and implementation science, and health economics and data. And the overall goal, again, is to improve patient and public outcomes, quality, delivery, and efficiency of healthcare services, but to do things that are relevant to people's lives. So that brings me to why we're here. PPIE. This exists largely through 2 panels, one of which I'm going to talk about today at our ARC, at the ARC North Thames. This one is called the Research Advisory Panel, or the RAP. We have 21 members, and we meet about monthly in 6-person sessions to collaborate on projects and review research based on people's lived experiences. So the idea is that we have this kind of pool of different sorts of lived experiences, and we pair them up with researchers, and I facilitate conversations where people can collaborate on research together. Specifically, panel members also collaborate on all kinds of other things that go on at the ARC. So some people get tapped individually to work on studies very, very closely with researchers. Some people help with governance. Some people help with big decision making, with the actual management of the organization, some with communications. It's all over the place. So just like it's great to do PPI throughout the research cycle, we try and do it throughout the organization, and even through further PPI recruitment and review of studies. So that's your background. Now I'm going to play Graham Norton and sit down on the couch. And let me introduce these gentlemen.
Can you hear me? Right, that's good.
Sudhir, could you please introduce yourself, sir,
Yeah.
first, and then we'll pass the mic to Martin, and then I'll ask the first question.
Okay, right. My name is Sudhir Shah. I'm a carer, and I joined Research Advisory Panel Group in its conception, because I was the original person who started all of this. The reason why I joined was because I was frustrated with this appropriate healthcare and social care weren't there. So I thought if I joined this group, I will be able to improve the healthcare and the social care. And so far, for so many years, it has improved, it has progressed, and I'm excited about it. And that has made me to keep going more and more and participate more. While we were there, I have made aware with the researchers the needs of the diverse communities. And that has been good because they have been putting that information in their research studies. And also improve the disabled people. And I noticed we find others who mentioned that. So this is also what we do, quite important. One of the reasons what we did quite a lot was to make the language simple, plain English. The reason we wanted to do that all the participants could understand well, and it helped both the researchers and us. I think that Will asked me, what was the most project I enjoyed? The recent project I was involved was with artificial intelligence. Now, that was a buzzword quite a while now, and it's still a buzzword now. We did a project on it to see what the patient's perception was on using artificial intelligence on healthcare. And that project gave us a good idea how, because we had a variety of people, as Will mentioned, we have a wide range of patient participants, which we call it PPIEs, not only from North Thames, but all around the UK. And that gives us a good idea of how patients view on artificial intelligence. In that project, I also got involved in qualitative analysis and coding work. Now, this is usually the work left by the researcher, professional researchers, but this helped me to understand better, even though I'm a lay researcher as a PPI, but this helped me. So in future, it will be quite good. Now, the future looks bright with North Thames ARC, because all the research projects include diversity and emphasis on better co-production methods. So I hope that we have a better health improvement. That's me. I'll pass it on to Mark.
Thank you, Sudhir.
You need when I got involved, I was doing research as a master's student at UCL last year, and I was doing that as part of a degree, a master's degree in creative health. And I still don't know what I want to be when I grow up. So I've got a lot of, I've had my fingers in a lot of different pies. And the idea, I think, of PPIE is that you can really be perspective. Now, I currently work as a psychotherapist, and when I was training as a psychotherapist, I think one of the best parts of my training that I enjoyed the most was when we'd get in a group and we'd study an imagined case, because you listen to other people talking and wonder how the hell did they think of that. I feel about that big, but basically you're getting lots of different perspectives. And so in my attempt to find out what I want to be, I've had experience of statutory sector social work, voluntary sector charities, legal sector as a barrister, health sector as a psychotherapist, the arts sector as an actor and singer, and I've got lived experience of addiction, dementia, polio. Basically, there are lots of ideas that I might come up with that other people wouldn't think of, and likewise, there are lots of things that other people would come up with that I haven't thought of, and I think that really is why I use it into research in the planning, preparation, and design of research. It's inclusive, it's democratic, it's interdisciplinary, and important.
What do you feel like, Martin? So Sudhir touched a little bit on what he thought here. Can we do it? That's what done. So Sudhir talked a bit about kind of his favorite parts of things that he's been involved in, and I'm watching the clock, so we got a few minutes left. But what are some things, and we can go back down the line, but what are some things, Martin, that you gained? So Martin's only been with us for just about a year, and Sudhir's been with us for several years, since the beginning, right? Genesis, right? Or whatever your persuasion may be. But so, Martin, what have you gotten out of it most?
Apart from being able to contribute, satisfaction in itself, but there's also, for my academic work, there was all the training and thinking about qualitative research, quantitative research, So it was an immediate benefit to me last year academically. And then just feeling connected. I mean, I'm a great believer in the NHS, and it's great to be able to contribute to it. I mean, it's a terrible state at the moment, if you don't mind me saying so. It's nobody's fault here, but being able to contribute just feels great.
Wonderful. And then, so real quick,
Yeah, sure.
there we go. Awesome. So, Sudhir, real quick, what's the thing that you've gotten most in all the time that you've been involved in research at North Thames?
Well, in early days, it was a tick box for the patients to be involved with the researchers. But engaging with researchers, talking to them, and telling them about we need a better feedback, and so that the next time when we engage, we could do something better. So it was a learning process, not just for me, but for the researchers. For me, that was a stepping stone to success.
So do you still think do you still find, is your experience still one of a tick box, or do you feel more collaborative now, or?
No, I'm sure Martin will tell me that he joined very recently, and he hasn't seen that tick box.
Yeah, there is a criticism that it's a tick box exercise. I do it last year, and I never felt that. So that's a credit to the people that come to us. They do seem to want to hear our views and are engaged, and quite clearly they're engaged with us.
That's great, gentlemen. So real quick, Sudhir already touched on this, but what do y'all think that PPI can hold for the future of research, of health, whatever it may be?
Future looks bright. Because we are engaging more, and because we are a wider group of people with various backgrounds, that will help the researcher to input in their research. And when they do one research project, when they learn more, when they go into the second research or any other research, that input will benefit them and in the wider society. So I think we are the catalyst for the better research.
I can't improve on that.
And you're right.
Thanks, Martin and Sudhir. Really appreciate you taking the time to join us here today and share a little bit about your own experiences and your motivations for getting involved in research. So I appreciate that very much. Are there any questions for Will? And I've got the mic. Oh yes, we're going to do that. Sorry. So, any questions in the room for Will, Martin, or?
Hi guys. I'm actually very curious because you, being a gentleman, brought in two gentlemen, and Christine, being a lady, brought in two ladies. Is there a particular?
That is an excellent observation.
Just a coincidence.
That is an excellent observation. So
Because I think we're giving the wrong impression that you don't work with ladies and they don't work with men.
So
that's not the case.
So there's a couple of layers. Let me peel back. When I send out invitations for a variety of PPI activities, and when I send them out to everybody. We have a lot of women represented on our panels. We honestly have more women than men. So there is a response to this where it's like these two dudes answered the call for this event. But there are, of course, lots of other dynamics at play that might advantage some men to participate in today's event more easily, not to undermine the experiences of the several women who are participating today. So there's a lot of things, but yeah, but there is a bigger critique of, I'm a white guy doing this, and
unless the research you're doing is actually particularly,
and this is because, and this is another wonderful point that white men can be an underrepresented group if you're talking about certain kinds of mental health research. And there is a need for a generous variety of experiences. And so, yeah, it's It's
just putting you again.
no, I appreciate it. They're wonderful questions. No, I appreciate you asking. I really do.
Just a coincidence, we got more women and they're very good. They provide a lot of support to us also. So I think we got few men, not many women.
Yeah. I think number wise there are more men, but it is interesting. It is a really interesting observation.
I will just say, you guys are completely on the spot, and I really don't think you're meant to in that way at all. But no, you're right. I think
Those who know me
so.
know
These are
I
things
like
that happen completely by chance, and there obviously wasn't any planning about that. But I think when we're talking about inclusion, when we're talking about diversity, it's actually having voices like that sometimes just say, oh, but have you noticed? You said this, or you did this, and it's like there is no one size fits all. There are, do you know what I mean? I think what we're saying is that actually, as long as we continue to check in out with ourselves, check in with each other, that hopefully will prevent us from kind of going too far down a path that's inherent with bias and prejudice and all the rest of it. But yes, and thank you. She is a troublemaker. Go on, no, go on.
Can I just mention, sorry if I mentioned there are no men champions. So hopefully watching us, they get encouraged to become men champions.
Yeah.
Nicely put.
Martin had a thing.
I was just going to say it's important to point it out as well.
Yeah, I totally agree with you.
Absolutely.
So thank you for pointing it out.
Thank you very much, everyone. Really appreciate it. So we are going to have, we'll stick with the break, just a very quick sort of 5-minute comfort break for those that might need to pop to the loo. And then we're going to come back and Jessica and colleagues are going to tell us a little bit about data. Thank you.
Y'all wake up.
Yeah. Oh yeah. Take a break.
Please come back in 5 minutes. Thank you.
Yeah. Yeah, cool.
Thank you. There are a couple of bottles put down here on the other side.
Any idea where this is in trying to just share the big rather than being able to see the bigger flat button involved. Yeah, relatively. Yeah, Christina around, so we didn't have to do the
and colleagues. Thank you.
Thank you, Nita. Just before we start, we've got a Slido coming up in a couple of slides. If everyone wants to get ready and scan, I think it's the third one down, just so you're prepared. But thank you for having us today. Today we're going to talk to you about inclusive orthopaedic research. So this is a project that our team has been working on. So today, as Nita said, you've got myself and Becca and Jamie, and we all work as part of the orthopaedic research team. So we're made up of physiotherapists, nurses, and a research coordinator. And we currently look after 18 studies that generally look at the best way to manage different broken bones or different injuries. And we work across multiple hospitals within Barts Health. And we basically go all over the hospital to try and find patients that are eligible for our studies, to inform them about the studies so that they can decide if they want to take part or not. Just to get you all engaged in thinking about orthopaedic research this evening, we wanted to ask you a question whether anyone has ever broken a bone before. So hopefully this opens up.
Sorry.
Failed at the first hurdle.
There'll be a lovely chart ready for us.
Bear with me.
Yeah.
There we go.
Lovely. We'll just give it a few more seconds for a few more answers. Oh, someone changed their mind. Yeah. Lovely. So sorry to hear that some of you have broken bones, but it's also good to know that our research is relevant to lots of you in the room today. So thank you for answering that question for us. Can I get back to the slides?
Yeah.
Thank you.
Oh. Where is it?
This one.
There we go.
Thank you. No, that's fine. Okay, thank you. So representation in research is a global problem, and this is something that, given that we're talking all about it today, research within the UK is especially interested in improving. So it's really well known that people that engage with research have a better outcome than those who don't, and hospitals that are research active have much better health outcomes than those that have less research activity. We also know that people who are from more deprived backgrounds and from ethnic backgrounds generally have worse health outcomes. So given all of this information, we were particularly worried that our studies at Barts Health weren't inclusive of our local population. Most of the studies that we run have a particular line within the exclusion criteria, excluding patients who are not proficient in English. And we know that East London is one of the most diverse areas in the country. So given all of this, we decided to investigate the representation of the patients seen within our research team. So our objectives of this project, of this service improvement project, were to assess how the ethnicity of the patients that agreed to take part in our studies compared to those that did not want to take part, and those that were screened out because they weren't quite eligible for the study, for example, because of a language barrier. We wanted to compare this to the local population data to ensure that the research population that we were seeing fairly reflects the people that are living in East London. So we went about this in 3 stages. So the first stage over on the left is our research data activity, and this was collected by our research team. So across 3 months between November 2021 and February 2022, we collected information about any patient that was eligible for one of our studies. We recorded if they consented to take part, if they declined to take part, or if they weren't eligible, and we included the reason that they weren't eligible as well, for example, language barriers. And we also used the patient ethnicity that was recorded on the electronic health records with this. The second part of this, so the one in the middle, We collected some hospital data which we accessed through one of the teams, and we basically looked at the same period of time as our research data, but we looked at all patients that attended the orthopaedic service, not just coming to the research team. So that's patients either coming in as an outpatient or having an inpatient hospital stay. And then finally, the data on the right, we accessed some of the census data from the Office for National Statistics. And basically, we compared this across the kind of two levels of our data. So within our data, we had 204 cases of our research data, which was predominantly female, 57%, aged between 5 to 100 years old, with a mean age of 51.5 years. And we had 24 patients who did not have their ethnicity recorded. So this data tells us the number of patients that consented to orthopaedic trials according to their ethnic group, and compares to the number of patients who declined to take part in orthopaedic research studies according to their ethnic group. Over to you, Jamie.
So here we can see sort of three broad groups of patients that Jess has already spoken about. As you can see sort of off the bat, they all look broadly quite similar, broken down in terms of sort of broad categories of ethnicity. So screened out would be, as Jess alluded to, so that could be for a reason of not having a proficiency in English to complete the follow-up. It could also be for clinical reasons. So most of our studies have to be either a certain age or below a certain age. So it could be the wrong age category with the right type of injury or fracture, or other clinical characteristics that mean you're not eligible to take part in the research, but you're within the research sphere, you're interesting enough for us to come and look at your notes, basically. Those who declined, we would have had a conversation with an approach, and the consultants would have been happy that they were eligible to take part in a study, but they, for some reason, one reason or another, decided it wasn't for them. So that's the proportion broken down by ethnicity of those who had that approach and that conversation, but decided not for themselves not to enrol. And then finally, enrolled is obviously people who've made it through that category and then decided that they chose to engage and to enrol and consent to the study. They look broadly similar. You can see maybe trending towards more of a percentage of white patients in the enrolled category. We did run the stats on it. We're very happy to provide them to anyone who's interested. But essentially, no statistical significant differences between either of those categories, basically. And as you can see in this one, it's in broad ethnic categories, so either sort of white, non-white, or missing. But if we then break it down if we break that down a little bit more in terms of white, Asian, black, or other, it doesn't tend to change the findings. If we then break that down across Whipps Cross versus Royal London, so Waltham Forest versus Tower Hamlets, where the ethnic makeup is quite different, it still doesn't change our findings. And then we break that down, the numbers are getting a bit smaller if we break it down into specific studies, but amongst our 15 or so studies, if we look at the proportion broken down by ethnicity of enrolled, screened, and declined, it doesn't change study dependent. So fairly consistent findings there when we run the statistics. So begs the question, are we delivering equitable research? So what we took from that is the design of our current research studies does not appear to significantly discriminate research status by ethnicity, which sort of suggests that the ethnicity does not differ between those that decline and those that enrol in research. However, we still thought there was a bit of an issue. When we start to look at this data, we can see where that issue may lie. Essentially, so does the ethnic distribution in orthopaedic research, so within our silo, reflect the orthopaedic service and then the borough population? And we can see that this is where the numbers start to look quite different. And essentially, we have a much larger breakdown of white patients who are involved in orthopaedic research, 72%, versus 43% who are accessing the orthopaedic department as a whole. Which in itself is fairly reflective of the borough data for Tower Hamlets, where the percentage of white patients is 45%. So there seems to be quite good congruency between the population makeup, if we break it down according to white and other ethnic group, in Tower Hamlets versus those who then make it into the orthopaedic department, and then quite a significant disparity for who then makes it into the orthopaedic research side of the department, and that tends to be nearly 3/4 white patients. So that's something we found, and this sort of similar data set, but just illustrates again the disproportion there as to where you're most likely to find a white patient within those three spheres, and it's far more likely to be within the orthopaedic research department rather than the department as a whole, basically. And again, just this was our sort of what we took from this side of the data was, again, if we think about patients who are unfortunate enough to have to access the orthopaedic department at Royal London, Whipps Cross, or within Barts, who live within our catchment and the population that we serve, they're fairly reflective until you get to our department, unfortunately. So there, we think that there is an issue in terms of, are we running studies that don't quite encapsulate, don't quite serve the population that we're meant to be serving. However, we were slightly encouraged by the fact that once you do arrive within the orthopaedic department, it doesn't appear to have too much weight as to what your ethnic background is. We tend to have a similar sort of spread of people who either choose not to take part or choose to take part, who, or for some clinical reason, are excluded from the opportunity to take part.
So taking those findings into account, we realised that actually the design of our studies didn't seem to be significantly discriminating research status by people's ethnicity, but we did find that people from a white background are more likely to be considered for research than people from other ethnic groups. So this kind of answered our first question of, are we delivering equitable research? But it brought up many other questions for us. We still didn't quite think we'd got to the bottom. So we have another question for you. How do you think we can make our research more inclusive? So please put your answer into the Slido. You should just be able to use the same poll as before. And we're going to come back to those answers that you put in a few minutes. So like I said, we still wanted to know why more people from a white background were interacting with research. So the results of this project led us to consider whether the problems our current studies were looking at were perhaps more biased towards injuries that people from white backgrounds might come into hospital with. This could be for many reasons and something that we want to explore a little bit further. So then this has led us on to another audit, which we are now currently doing, looking at why patients are attending BART, so any of our BART sites, so Royal London, Whipps Cross, hospitals. So we want to look at the reasons that they're attending hospital and their ethnicity to compare this to our current studies.
Sorry, you couldn't move the Slido on.
Oh, this back to the Slido. Yes.
It's not.
Oh, the questions.
Apologies.
Yeah. So we've started another audit, kind of looking at the reasons why all patients come into the hospital sites, looking at their ethnicities that's recorded on the electronic patient record, and then comparing this to the data we have that we've talked about already. We also want to have a look at how we can involve patients and the public more within this project, because we obviously want to develop this alongside our local community, and rather than just thinking about reasons without involving them. Yeah, thank you. So this was us at a previous public engagement event, which was hosted by Well One last year, where we got to speak to some of the local community about who we are and what we're doing. We're going to be planning more events and public sessions to explore the results of this project and what research is important to the people that live in East London. We also went to the Festival Communities last year, hosted by Queen Mary, and we're going to be attending again this year. So hopefully we'll see a few of you there in Stepney Park. And we also have a PPI group that's always looking for new members, and the details of that you can find on the website, which we'll put the details up at the end. We really want to be more involved with our community, with the hope that these activities will help us to understand the needs and research priorities of underserved groups in our local community, which will then help our team to select and design new studies that are relevant to the people living in East London. We're meant to have the results from the Slido, so.
Yeah, here we are.
Yeah. Oh, great.
We're on the same lines.
Yeah. Yeah. These are all really good points. Let's go into the community, fund translators, engage the community.
So translation comes up.
Lots of translators. Yeah.
That we really need to take and note.
Yeah.
Excellent.
Yeah. We'll just leave it another minute or so. Yeah. Oh, more typing. Accessible visits, family involvement, yeah.
Brilliant. Thank you to everyone for including and involving yourselves in that.
We've just got our contact details. Great, yeah, so thank you for engaging with that. That's the end of our talk. So if you have any other questions or comments, please let us know, because we would obviously love to have your opinions. Our contact details are just there if you want to get in touch with us.
So if you wouldn't mind, Charles, I'm going to actually ask if we can skip straight on to our next speaker, and then if we've got a few minutes at the end, we'll do a round up for questions to both of you and for the next.
No worries.
So without further ado, I'm just going to wait for James to line up Vanessa's slides. And Vanessa, hopefully you are online and poised.
I am.
Okay. So our final speaker of the evening is Dr. Vanessa Appiah, who is going to be sharing information about a new project that she has launched in the last year called Alive. I won't go too much into it. There is an acronym that's coming up on this screen there, which is Amplifying the Lived Experiences of East London Communities. Vanessa, are you online?
I am. Can you hear me?
We can hear you, and welcome.
Perfect. Thank you so much, and thank you, James. I'll do the next slide. Aspect. Perfect. So good evening, everyone. So as Nita said, I'm Vanessa Appiah, and I'm just going to share with you some work I'm doing, which is under the acronym ALIVE. So amplifying the lived experiences of East London communities. So just thinking about the rationale of this work, there are clear and persistent inequities when we look at health outcomes, particularly amongst women of Black African and Black Caribbean heritage. But then when you look at relevant data in these areas and amongst these groups, we see that there are significant inequities in representation. And that representation and those inequities are amongst research participation, and also for these groups to be centered in research, and also for people from these backgrounds to be leading the research as well. And essentially, my studies really focus on the fact that we need to better understand the drivers of poorer health outcomes and understand the health needs of women of Black African and Black Caribbean heritage, so that this can inform the design of more responsive interventions and strategies. And in terms of the research questions, my main questions are, what are the lived experiences of women of Black African and Black Caribbean heritage in North East London, particularly with regards to sexual health, reproductive health and HIV, because those are the areas that I specialise in. What are the research topics within these areas that are prioritised by women of these heritage? And then also thinking about what are the most effective approaches of engaging them in health interventions and related research. So it's mixed methods and an observational study. And really key to it, yes, by design, it tackles inequities by focusing on these groups. But what's really important is making sure that we get representation from these groups to be involved in the research, and also recognizing that I've used quite broad terms of Black African and Black Caribbean, and we know that these are really heterogeneous groups. And so for me to engage and work with these groups, it's been really important for me to think about what are the right ways of engaging these communities, identifying them, and then also allowing authentic and really meaningful engagement, which we've been reflecting on today. So as part of this, I'm using an adapted version of the James Lind Alliance, so James Lind, who Nita mentioned earlier. And some of you may have heard this process, priority setting and partnership process, that has been used in really trying to prioritize research agendas amongst in certain disease areas. But in our case, we're adapting it because we're looking at a specific group of people, and that's quite different from the James Lind Alliance process, but it's being guided by James Lind Alliance and facilitators and being endorsed by them. And I've used and adapted this process in another piece of work looking at COVID outcomes in racially minoritized communities, and which has been really successful. So using this aspect of co-production and co-design, and it's, as I said, it's mixed method. So if we could go on to the next slide, please. It's quite a busy slide, but just highlights. Yes. So the first phase is establishing a priority setting partnership. So establishing people from the community, from community-based organizations, residents, to be part of a partnership group that will support the design of the questionnaires that are involved in the study, and also support dissemination, both of the surveys and also of the outcomes as well. The surveys, we're aiming to engage at least 800 women from across that are residing in Tower Hamlets, Waltham Forest, and Newham. Sorry, I think there could be an issue with my slides. Is there a? Can you see my slides?
Yeah.
We can.
Okay, great.
But I don't know if people online can.
Oh, okay. I'll keep on talking.
They can. No, they can.
Perfect. Great. So the first aspect, as I've said, is the questionnaire. And so we're aiming to recruit 800 women across North East London boroughs to engage. And then there will be a qualitative aspect. So a subsample of these respondents will either participate in focus groups or in one-to-one in-depth interviews. And then there is a phase in which I'm wanting to do a longitudinal feasibility sub-study. So essentially, I'm going to be recruiting a subsample of women of Black African and Black Caribbean heritage that are also living with HIV. And I'm going to be recruiting them for a survey and an interview, but I'm aiming to review them longitudinally. So I will be engaging them every year for 3 years. And so just to have a longitudinal aspect and see, do their lived experiences change as the years progress? And I think particularly when we think of what's happened in the last 3 years, and yes, with COVID, but also with the cost of living crisis and how that's really influenced people's lived experiences, that's been one of the key drivers to supporting this this longitudinal feasibility. And then afterwards, within that, as part of the survey, we will be identifying research priority areas that people have identified. And then we will be sending out a prioritization survey of these research topics, just to understand and prioritize the research topics for this group as well. So there are a number of strands of this research, but I'm really excited to center this group, give an opportunity for different approaches for engagement in research, whether it be surveys, whether it be the interviews, whether it be the prioritization survey, just to understand people's lived experiences, but also their research priorities as well. And then ultimately, the aim is to bring all this insight together to design an intervention and pilot an intervention that really responds to some of the needs that have been identified in the survey. So this is a program of work that will be going on for the next 3 years. Next slide, please. And just to highlight where we've gotten to, so we've had extensive PPIE work. So there are a number. We've had a number of focus groups to shape the protocol and also the next phase of designing the survey. We've got our HRA approval. We have a website which is highlighted there, and I urge you to go and look at it. It's the landing page which has been launched, and the expanded content comes next week. We formed the steering group of community organisations and residents, and we've also recruited a lead community collaborator, and we're in the midst of recruiting Alive ambassadors. So these are Black women living in East London that will be ambassadors, another word for champions within East London, and there will be the first brunch for these ambassadors to learn about the research and gain their insights on the right way to engage and disseminate is taking place in July. We've started to draft the survey, and there will be a Delphi exercise, which is just to work with the steering group to help us decide what are the key questions that we need to be asking within the survey. And things have moved on quite at pace, but a lot of the work will be happening over the summer into September, October. So looking forward to sharing with you the next phase of outcomes. Next slide, please. Great. So I've just left my contact details there, and I'm really happy to go through any questions that anyone has, perhaps at the end. Thanks so much.
Brilliant. Thank you, Vanessa. And we are running a little bit behind time, but it would be really great just to maybe, if you can bear with us, we can take a couple of questions. So if there are any questions for Jessica, Rebecca, and Jamie, or Vanessa online, now is your time to ask. Otherwise, give it a minute for people to think about it. You knew this was coming. You should have had them ready. Are there any questions online, Laura?
Doesn't look like it.
No.
No.
Okay. So, we've got one question.
Only a simple one for Vanessa. How do folks eligible folks get involved? Do they need to go onto the website and register, or?
Yes, so thanks, David. Yes, so there will be different modes of engagement. So there will be on the website, they can register interest, and then we will be putting the survey and link on there. But also with the ambassadors, we're aiming for them. There'll be some paper versions that will be disseminated. And also what I found with some of the other work that we've been doing is going to some community centres and having a facilitator there, and then giving it out, whether it's by paper or supporting someone to go through the questionnaire with them on an iPad. So I'm really aiming to have different opportunities for people to engage.
Thank you. Any other comments or questions from people in the room or online? I've got a microphone for you. It's Sultana. Thanks, Sultana. Who's your question for?
It's for Vanessa. Vanessa, as you were speaking there, I was thinking of Positive East in Tower Hamlets, and wondered if you've engaged with them. And in terms of recruitment and sort of publicising, I think I'm the queen for that on my social media. So I was just wondering, like, if you'd also like to come to Katie's team to give a presentation, as well as maybe work in collaboration. Also, the other thing was, if you have the documents or surveys in different formats, then it's probably easier to disseminate through WhatsApp and social media as well. And the other thing I forgot to mention earlier, but had a little chat We both.
No, it's suddenly gone on. Just press the button on and off again and see. That's you going.
Oh, okay. So I think having lived experiences really matter in things like this. And you probably know, Nita, that through my Bell's palsy journey, I really want to see more research out there regarding Bell's palsy. But I also wanted to mention how brilliant you have been, and Christine and the team, in terms of accessibility needs, in terms of helping Lynn Sharifa achieve, these milestones. We couldn't have done it without you, and I really wanted to thank you both.
And I took the same because for people like me, without transport, I would not be here today. So it's really important that that you make it accessible in whatever way you need.
Even though we sent you to the wrong place.
I know, it doesn't matter. That happens. That's life.
It goes to prove that we are all human and we all occasionally. Thank you so much, both of you. Vanessa, we can obviously put you in touch with Sultana.
Definitely. Thank you so much. And take on board all your suggestions and we'll definitely engage. And just to reassure you, I work really closely with Positive East, and I've just done a project with them, Women for Women, which has been kind of scaling up sexual and reproductive health awareness and education amongst women in East London. So yes, very looped in with them, but I'm excited to connect with you. So I'll connect with you online. Thank you so much.
Thanks again to round of applause. We're going to close today's session, but before we go, I just wanted to, had we not overrun so badly, I'd be taking a little bit more time over this next bit. But for those of you who may be familiar, we do run the NIHR's Patient Research Experience Survey across our 5 hospitals at Barts Health. We've been running it for about 5 years. I was going to do a short presentation, but I'm going to leave that for another time to share the results with you. But I did want to just give a shout out to the teams that were involved in helping us to deliver the survey to our NIHR studies over the past year. So by October last year, we set a target last April by our Clinical Research Network. They set it at a rather modest 3% of our overall recruitment to NIHR studies last year, the previous year, and that target was 455. Now, pre-pandemic, we were returning between 600 and 800 surveys a year, so we really didn't think it was going to be a problem. Come October, when we had 62 surveys submitted, James and I looked at each other and went, oh, don't think this is going to be quite so easy. So James put a super amount of effort into communicating with all of our teams. And I just want to say a huge thank you for everyone who helped to deliver it. We ended the year with 513 surveys. And 3 teams in particular really pulled it out of the hat. So we wanted to just give them a little bit of a token of appreciation. So I don't know if Salma is in the room today. Yep. Salma, who represents the acute and critical care unit at the Royal London, is that right? I'm not going to ask you to come up, don't worry, because I haven't got anything to hand you. But we are going to award you a small gift, an Amazon voucher for your team. And that would be £75 coming to you guys. You managed to return how many surveys?
198.
198 of those 513 came from our ACCU team. So I want to say a big thank you. I also want, we've got second and third prizes for our cancer team who managed to return, James is going to 89.
For children's were
Children's were second with 89.
89,
so
yeah.
Our members of our children's team in the room today. Well done to you guys. There's members of that coming to £50 as well to share with the team. And then our cancer team, I don't think we've got anyone from the cancer team here today, but they also have got our third prize and a voucher for £30 is coming to them in the very near future. So I just wanted to mention it here because, of course, if any of our teams are listening, either in the room or online, and haven't taken part in PRES, there might be some more incentive for you to get involved this year. So PRES runs all year round. It's a great opportunity to get feedback from our participants about their experiences of taking part in our studies. And hopefully we'll have more to share with you in terms of the results for last year in a few weeks. I'm not going to hold you up any longer. I just want to say thank you so much, everyone, for attending in person here today, and for everyone who's attended online. I do apologise, we had a slight technical hitch with Vanessa's camera not working in the lecture theatre, so they couldn't see you, Vanessa. But I think that's it. We will be sending a feedback form out to you all, so do please take a few minutes to complete that when that reaches you. It's always helpful to us to have that feedback so we know how we're doing with these events and we can plan for future ones. Please join us, for those of you in the lecture theatre, please do join us for some drinks and canapes just outside in the lobby. And this is me signing off for International Clinical Trials Day 2023. Thanks again, everyone.